Hello again, people. So this time I'm going to do a talk on stable angina. Hopefully this is going to be useful. I think this was a bit more interesting, at least for me to put together compared to hypertension, because there's a lot more symptoms and signs to look out for compared to hypertension. But I apologise if some slides do get a little bit too complicated. I've tried to keep them fairly simple. There are only 11 here, but some of them are a little bit packed. So let me know what you think if it's a bit overly complicated. And we'll see how we go. So stable angina. By definition, before we start out, stable angina is angina that recovers at rest. All angina means is chest pain that's related to the heart. Stable angina means that chest pain that's related to the heart goes away at rest, and it comes on exertion. Okay? That's opposed to unstable angina, which I'll talk about later, that's included in the acute coronary syndromes, which is a bit more serious and kind of a step up from stable angina, where rest doesn't allow recovery from angina. So the etiology of angina is really surrounding the coronary arteries. If the coronary arteries become obstructed, and this is by far the most common cause for angina, then if the coronary arteries become obstructed, then the oxygen that's required for the myocardium to function can't be supplied, and when that happens, the patient experiences pain. There are several reasons why those arteries might be obstructed. A couple here that I've put are atherosclerosis, which might develop in the coronary arteries themselves, or an embolism. That might be embolism from a thrombosis, from a thrombus somewhere, or it might be a fat embolus. So anything that obstructs those coronary arteries. There are a couple of other causes of stable angina. Really, coronary artery obstruction is by far the most common. As far as I understood it, vasospasm and arteritis are rare. Coronary artery obstruction is definitely the most common, but vasospasm and arteritis are rare. Vasospasm can be caused by various things. I think one of them was smoking, but a couple of the other ones were cocaine use and cold weather. Vasospasm is very difficult to diagnose because it only comes on for a short period and then goes away. And to detect it with the methods that are used to investigate, you would have to catch someone just as they have a vasospasm. And if you don't know what's triggering that, and you can't trigger it yourself, it's going to be very difficult to replicate and therefore to diagnose. Whereas something like coronary artery obstruction, you can find through the tests that I'm going to talk about later. Arteritis is an inflammatory disease of the arteries, and that could involve the coronary arteries, which just causes a narrowing of the lumen. So several factors can make stable angina worse. If you think about what causes stable angina, like I said, an oxygen demand mismatch, basically where the myocytes aren't getting the oxygen they need. Following on from that, it makes sense that something like anemia could make stable angina worse, because in anemia, your blood is less capable in carrying oxygen, and it's the oxygen that the myocytes need to work. So if you have anemia and it's severe enough, I think it does have to be quite severe to actually worsen angina, but if it's severe enough, it could make the angina even worse. Left ventricular hypertrophy causes a couple of things that can exacerbate angina. One of them is that the blood has to travel further to get to the subendocardium in the myocardium, which is the innermost layer of the myocardium, in reference to the ventricles and the atria. So because blood has to travel further, more oxygen is taken from that blood as it travels towards the subendocardium by the earlier levels of myocytes. Also, the more muscle that you have, the more oxygen it requires as a whole. So if you have more muscle than you have oxygen, you're going to get pain again. And there are several things that could cause left ventricular hypertrophy. And I suppose you'd also get angina if you had right ventricular hypertrophy, but just for now, in terms of left ventricular hypertrophy, things that can cause that as anything that increases the afterload for the left ventricle. So hypertension is a high pressure for the left ventricle to pump into, as with aortic stenosis. It has to generate a high pressure to pump through that stenosis, that narrowing of the aortic valve. And you could also have cardiomyopathy, several things like that. Thyrotoxicosis is something that can cause atrial fibrillation, but also increases the activity of the myocytes, because the thyroid's hormones regulate metabolism, and the more thyroid hormones that are released, the higher the metabolism rate is. Emotional or physical stress. I've put like surprise or exercise here, but it could be pretty much any kind of emotional or physical stress, just anything basically that raises the heart rate, anything that increases the myocardium's demand for oxygen. The symptoms of stable angina, they only occur when the coronary arteries, if we're talking about occlusion to the coronary arteries, which we almost always are, the symptoms only occur when there's an occlusion of those arteries by more than 70%. So the occlusion actually needs to be quite far on before any kind of pain actually sets in. And the pain's quite a specific kind of pain, and it's important to figure out exactly what nature the pain is from a patient when they come in with chest pain, because angina tends to be a dull, crushing kind of pain felt behind the sternum, and this can radiate to the jaw or the left arm. It doesn't tend to be a sharp pain, it doesn't tend to last just minutes, and it tends not to be a kind of pain that you can put a pinpoint exactly on, because it does tend to radiate a bit. It might not always radiate down the left arm and jaw, but at least around the chest area. The pain tends to last for hours. By definition, in terms of stable angina, it improves with rest. It could cause syncope, and that's just if your heart's not able to pump out enough blood to support consciousness, to support your brain with nutrients. If you have a sudden drop in cerebral perfusion, then that could happen. But that's quite severe for stable angina. That sounds a bit more like something like an MI, but it's still possible, as far as I was told, to have syncope in stable angina. But it might be a good idea to look that up just to figure out exactly why, if you're interested. So dyspnea on exertion is another kind of thing that follows on from syncope. If there's not enough forward flow going out of the aorta into the rest of the body, the ejection fraction's down, the stroke volume's reduced, then the diastolic volume will still be high after systole has finished, and as that builds up, you'll get a kind of traffic jam going into the lungs, which can cause pulmonary edema and dyspnea, because the levels of oxygen that you can transfer into your blood is reduced, and that will result in a build-up of carbon dioxide as tissues don't get quite as much oxygen as they need, and that will generate a respiratory drive, an increase in respiratory drive. Just bear in mind that diabetics and the elderly can have reduced sensitivity to pain. They could be feeling a bit nauseous. That's another symptom, or they might be a bit sweaty and pale, which I'll talk about in the signs. But they might not actually have any pain, and it turns out they're actually having angina, or they might even be having an MI, so a myocardial infarction. So that's something that needs to be considered as well. So onto the signs. This slide's a little bit full, but it's not too bad. It's not too complicated. Most of this is just signs of exacerbating or causative factors rather than the actual signs of angina. So if someone's having angina, obviously they'll be in pain. They'll probably be either verbally telling you, or they'd be sort of clutching at their chest. If they're clutching at their chest, making a fist sort of shape around their heart area, that's considered Levine's sign. It's not a very fancy way of telling that someone has chest pain that relates to the heart, but it gives you supposedly those that have chest pain that relates to the heart. It was found that they have a tendency to make a clenched fist and put that towards their chest. It's not exactly diagnostic, but it's something to look out for. Other signs are tachypnea, tachycardia, raised heart rate, raised respiratory rate, pallor. If perfusion is low, they may not be having a full MI, but the myocardial workload potential for work may be reduced, and that may reduce perfusion of some of the peripheries, like the face, the hands, the legs, and they may become cold and pale. The patient may also become clammy or sweaty. And signs of some of the causative or exacerbating factors. This is going to be a very long list because these are various things, of which there are many that can cause or worsen angina. But in anemia, you'll see pallor, which you may see in the conjunctivae. It's one of the first places to go pale in anemia. The apex beat which is usually in the fifth intercostal space, midclavicular line, might be particularly prominent if they have hypertrophy, which is an exacerbating factor of stable angina. Another exacerbating factor is aortic stenosis, which causes the hypertrophy, but if you can pick that up, that might be a clue. An aortic stenosis is an ejection systolic murmur, so it's a murmur that occurs throughout systole. It tends to be quite a loud, harsh murmur, which has, when feeling the pulse, a plateau pulse, which has a sort of steady rise. You can also, if the aortic stenosis is severe enough, hear it radiating to the carotids. You might see signs of heart failure as well, which can cause angina, stable angina, and those signs are just things relating to congestion from the left ventricle, because the diastolic volume is still raised. You have raised end diastolic pressure, so you may hear basal crackles from pulmonary edema in the lungs when you auscultate. You might see a raised JVP because the blood isn't entering the right atrium due to a raised end diastolic pressure. And that raised end diastolic pressure might just be because of raised lung pressures, which is raising the right ventricular pressure, which is raising the right atrial pressure, which means that it can't fill from the jugular vein. So the jugular venous pressure will raise. And peripheral edema as well. Often their legs will be swollen, and so on. So on to investigations. These are there are quite a lot of investigations to do. there are quite a lot of ways to try and identify a stable angina, and sometimes it can be quite difficult, from what I understand. So full blood count, FBC, is a good idea, because then you can tell whether or not the patient has anemia. And it can also help you rule out various other things. Lipids, cholesterol is one of the main causes of stable angina, because it causes an obstruction, or it has the potential to cause atherosclerosis and thereby an obstruction to the coronary arteries. Fasting glucose, to tell if the patient has diabetes or something like that. Electrolytes, if the electrolytes are disturbed, like sodium and potassium, conduction through the heart might be altered. That could cause some arrhythmia, which then results in impaired filling, perhaps, and chest pain in some way. I don't understand that enough to explain it to you guys, but trust me, it's one of the things to look for. Liver function tests are also useful. And also, like I explained, thyroid function tests, because of the potential for thyrotoxicosis to cause stable angina, atrial fibrillation, that kind of thing. Troponin is a myocyte protein that can be released when myocytes die. And it tends to be raised if someone is having an acute coronary syndrome, so it's important to rule out that person has had any actual death of myocytes. So troponin tends to peak after 13 hours beyond the event. So if someone has chest pain and it's just started, and that minute you check the troponin, they might actually be having an MI, but you can't tell, because the troponin won't increase until about 13 hours post the event. It's very sensitive though, and supposedly moderately specific, because a few other things can release troponin. For example, a pulmonary embolism can cause troponin to increase. So can sepsis and dysrhythmias and subarachnoid hemorrhages as well. Another thing to measure, which is kind of very similar to troponin, is CKMB, which is another myocyte protein that can be released into the blood. Troponin C is not considered useful, and the liver function tests, in terms of telling you whether or not there's been an MI or any myocyte death, to rule that out, that's not particularly useful. Liver function tests are considered non-specific. Chest X-rays are useful as well. They are useful in ruling out several other things. They can be useful to try and tell whether the patient has cardiomegaly, for example, which might suggest heart failure. And they can also be useful for looking at pulmonary edema, which can blunt the costophrenic angle. And there are several other things you can see in the chest X-ray pulmonary edema, but I'll talk about that in another video. An exercise tolerance test is another way of investigating stable angina. If you get a positive exercise tolerance test, that's when you find someone who has chest pain on exertion and ST depression. ST depression suggests that the patient is having ischemia in their myocardium, and that's expected to go away with rest following an exercise tolerance test if this is stable angina. It can't exclude coronary artery disease if it's negative. So if it's negative, that doesn't necessarily mean they don't have coronary artery disease, but it is actually a good sign in terms of the prognosis. The ECG, it's normal in more than 50%, and I suppose that's because there's not really any change in the conduction through the heart as such in the majority of the time, so long as it's not too severe. Um, it's very, very important to do an ECG immediately if someone has chest pain. That's the first thing you would do, because you want to rule out an MI. If someone has an MI, you've got a very short period of time to start acting on it to give them the best chances of best prognosis and survival and all of that. So first you have to rule out. I should have probably said that first when we got to investigations. Actually, ECG is the very first thing you need to do. You might see ST depression on the ECG without even doing the exercise tolerance test to look for it, and that can suggest that there's some ischemia in the myocardium. Not that there's necessarily been any myocyte death, and something like ST elevation rather than depression is a much, much more serious, urgent sign, and is considered basically the worst MI that you can get, with NSTEMI being still very serious, non-ST elevation still being very serious, but slightly less so. But I'll talk more about those in the acute coronary syndromes. Oh, and there's a couple more investigations which I didn't put on here, because I thought the slide was already getting pretty long. But you can also do, if you're not quite managing to figure out whether or not someone actually has stable angina, and you want to differentiate that from various other things, then you might want to do a myocardial perfusion scan, which is an exercise test. It can be done as an exercise test, or it can be done as a pharmacologically induced stress test, where you give them something like dobutamine to increase their heart rate, and increase the demand for oxygen of the myocardium. So it's an induced stress radioactive test. So you give a radioactive isotope to the patient. This is taken up by the myocardium, and they're scanned to show that isotope and see where it's taken up. And it won't be taken up by any material which has died. If there is material that's died there and you don't see any myocardium that's died there, and you don't see any radioisotope that's active on this scan, then that means that there's been an infarction at some point, a myocardial infarction. So you might, however, see that when you start to increase the patient's heart rate, slowly the tracer, the radioactive isotope, isn't taken up so much by certain regions of the myocardium, and those are the regions that would be considered to be to have reduced blood flow. So if you can see tracer everywhere in the myocardium at rest, that means there's been no infarction, and then you increase their heart rate pharmacologically or by exercise, and you may see that reduce in a certain region of the myocardium, which suggests that that region is being supplied by a coronary artery that's obstructed, or at least partially obstructed. You can also do a CT coronary angiography. It's not used if you know someone has coronary artery disease, because it can't actually quantify the degree of coronary artery disease. You'd need to do an angiography, a lumen-based angiography for that, which is more invasive. But this CT coronary angiography can identify where a coronary artery is narrowed, but it can't actually quantify it. So moving on to the differential. Sorry, this text is a little bit small on this slide, but basically the best way to think of the differential diagnosis for chest pain, and I guess for several other diseases, is to start superficially and move to deep. This differential list is not extensive at all, but it just gives an idea of some of the various things that can cause chest pain that might sound like an MI or stable angina, but really isn't. So someone might have shingles, which affects regions on the skin that relates to dermatomes, and that might cause chest pain. Same with viral mastitis. which can be very painful. Musculoskeletal pain due to Coxsackie infection can cause pain in the intercostal muscles. Bone pain like costochondritis. Cancer, you can have metastases to bone, and may get that in your ribs, or fracture to your ribs, which can cause chest pain. So if a patient comes in and says they have chest pain, it could be several things. But because an MI is the most imminent and most dangerous thing, an ECG is always the first thing you do, even if you, well, depending on how sure you were. If it was something obvious like shingles, you wouldn't do an ECG, but if it was more difficult to tell the difference, then you would jump to ECG first, just to be safe. So the esophagus can give chest pain if you have something like gastric esophageal reflux disease. The pleura have nerve endings that can relay pain. If you have pleurisy, which is inflammation around the pleura, which line the lungs, then that will give you pain, which you may get from different types of infection or some other things, which we'll talk about in some autoimmune changes like Dressler's syndrome, which I'll talk about in the acute coronary syndrome section. Pleural effusion, pneumonia, pulmonary embolism, PE. Those can all cause chest pain as well. Peri or myocarditis, pericarditis, myocarditis. Those can both cause chest pain. So can aortic dissection. Aortic dissection's probably the most, definitely the most deadly on there, apart from maybe pulmonary embolism. So that needs to be imminently. So by deadly I mean like imminently. So that one needs to be sort of differentiated as quite an important one to look out for if someone says they have chest pain. Aortic dissection tends to be quite extreme chest pain that radiates to the back as well. So if someone has chest pain that radiates to the back, it's worth investigating for an aortic dissection immediately, because those are considered a medical emergency, just like an MI. And also you could just have referred gut pain. I say just, but that could actually be from a serious cause, but referred gut pain could cause angina as well. Well, not angina, but something that looks like angina. So the treatment, first of all, in terms of treatment, is to modify risk factors so that you're going to be trying to avoid the patient from having an MI, to try and divert them from any further coronary artery obstruction. So you'll want to try and modify the risk factors, of which there are multiple, but the main ones are cholesterol and hypertension. Encouraging the patient to get good exercise is also useful. Reducing their weight is good. It reduces blood pressure, and is a major risk factor. Diabetes as well. Diabetes causes, if it's uncontrolled diabetes and you have high levels of glucose in your vasculature, that causes immune responses in the vessel walls, which causes inflammatory changes that sort of precede atherosclerosis. So that gives you a risk of thrombus formation and emboli. So controlling diabetes is important as well. Diet is important in terms of just controlling the lipids that are taken in, and trying to increase your HDL and reduce your LDL, those different types of cholesterol. LDL are considered the more threatening type of cholesterol, and HDL the better type, because they take cholesterol and lipids back to the liver. I think I'm right in saying cholesterol, they probably take also triglycerides, and LDL take cholesterol from the liver to the periphery. So reducing LDL is important. So eating the right kinds of fats, like say olive oil and oily fish, is better than eating something like a fry up of bacon and eggs and things. So on to the pharmacological treatment. Um, Beta blockers are important to reduce the inotropy and chronotropy, the heart rate and the strength of contraction, and reducing the blood pressure. Beta blockers also manage to do that. They do several things actually. They also mop up reactive oxygen species from around myocytes, which reduces the potential for a myocyte dying. Um, and they increase the diastolic coronary artery perfusion time, and that's just because they decrease the heart rate. So there's more, the heart spends more time in diastole, therefore there's more time for the heart, for the coronary arteries supplying the heart to be perfused. Those are only perfused in diastole. I-finely channel blockers, they work at the sinoatrial node and reduce the heart rate. Reducing the heart rate, of course, like I explained, reduces the oxygen demand for the myocardium. Calcium channel blockers do a very similar thing if you're using the rate limiting ones, which are diltiazem and verapamil. But here I've put nifedipine and or amlodipine, those kind of ones, because they cause vasodilation, which reduces the afterload. When you reduce the afterload, you have more potential for forward flow. So the lower the afterload, the more cardiac output you can get. Nitrates also cause vasodilation, although they cause a more widespread vasodilation across the veins and venules and the arteries and arterioles, whereas calcium channel blockers are mostly just the arteries and arterioles. So those have a slightly more profound effect, though calcium channel blockers are the more long-term kind of treatment. Nitrates like GTN, glycerol trinitrate, or isosorbite mononitrate are good for controlling the symptoms of stable angina. If someone has chest pain and they take their GTN spray, that can get rid of the symptoms, the chest pain, very rapidly. Potassium channel openers, similar to I-finely channel blockers, but just working in a different mechanism to control the heart rate. Examples of those are nicorandil. And because they open the potassium channels, they cause hyperpolarization and reduce the chance for more action potentials to be fired and more contractions of the heart to occur, increasing the refractory period. So aspirin and clopidogrel, these are mostly work as anticoagulants. These are extremely useful therapies for reducing the potential for thrombosis and emboli formation. So aspirin works by inhibiting thromboxane, and it actually reduces mortality by 23%. So you might think that aspirin is kind of just a tablet that you take when you've got a headache or something, but it's actually a very significant and effective drug for reducing death in cardiovascular disease. It's a major one, and it's used in the acute coronary syndromes as well. And so is clopidogrel. So clopidogrel is an antiplatelet drug, and it works by antagonizing the ADP receptor. And that causes 2B3A inhibition, which prevents fibrinogen, fibronectin, and von Willebrand factor from forming a complex for the common pathway in coagulation. That's a bit of a mouthful, and that's quite complicated. That's really to do with the thrombotic pathway, and that's probably not really worth going into too much. But clopidogrel is a very useful drug in preventing the potential for thrombosis. Prasugrel is something with a very similar mechanism to clopidogrel and is an alternative. Statins and fibrates both reduce cholesterol, although statins are the main one, because they reduce the actual endogenous production of cholesterol, which is the main source of our cholesterol, not the diet, although the diet is another source that's important to control. Um, but statins actually reduce mortality by 42%, so those are very, very significant treatment in stable angina. So there are just a few final things to say, and these are about the complications of treatment and the side effects and the interactions. There aren't that many more. So beta blockers, if you suddenly stop beta blockers, you can get a rebound MI. So suddenly stopping beta blockers is a very bad idea. They have to be kind of weaned off. Beta blockers also aren't given in asthma, which is because in asthma you want to avoid you want to stimulate the beta receptors in the lungs rather than blocking them, because when you stimulate them, that causes bronchodilation. If you block them, that causes bronchoconstriction, which is the opposite of what you want in asthma, where you've got bronchoconstriction anyway. So beta blockers can potentially exacerbate asthma symptoms and need to be avoided in asthma. The same with with aspirin, though for slightly different reasons. Leukotrienes cause constriction of the bronchioles as well, and when you give aspirin, that causes a shunt down the leukotriene pathway because it inhibits the pathway which produces thromboxanes and stimulates clotting. So the side effects from beta blockers include fatigue, lethargy, impotence, bradycardia, and bronchospasm. Bronchospasm, like I said, for asthmatics is very important. The effects of beta blockers can be additive when you use other medications that have a similar effect on the heart by reducing inotropy and chronotropy, like calcium channel blockers, because myocytes require calcium to be able to contract. It's one of the major contractile proteins and also one that's involved in sending the action potentials. NSAIDs, they antagonize the antihypertensive mechanisms that beta blockers have. So, if you're trying to treat someone's hypertension as well, then it's not a good idea to give them NSAIDs like ibuprofen. But probably even if they don't have hypertension, it's useful to be able to reduce their blood pressure unless it's low already, which is a contraindication, because that will reduce the afterload and produce an increased potential for the heart to get more forward flow out of the left ventricle. Beta blockers can also mask hypoglycemia, so you need a bit of caution in diabetics. So aspirin is a major cause of admission with GI for admission with GI bleeds. Although it does block, or at least help to block thrombosis, it therefore also has the potential to cause bleeds. Calcium channel blockers can cause ankle edema. And this ankle edema, I don't understand why, but it can't be treated with, or it just doesn't really react to diuretic therapy. Okay, so that's it. That was a bit of a complicated one. I think stable angina is a bit more of a has a lot more to it to talk about in terms of what I've learned, at least so far, compared to a lot of other diseases. So it's been quite a long one. Hope to see you next time, guys, and have a good one.